A very warm welcome to the talk today, which is very different. And I'm sure you're going to enjoy the talk. And we are going to have a session where we'll discuss with each other. So, understanding the biology of body weight regulation in children and how to prevent type 2 diabetes. This is a very interesting topic because a lot of new things in this topic, and I'm sure you're going to enjoy the talk. Now, what is obesity and how is it measured? This is very important. Excess or abnormal accumulation of body fat is obesity. Most common parameter that we use is body mass index, where you know that weight in kg is divided by the height in meter square. Now, as far as children are concerned, what you do is underweight children are where the BMI is less than 5th percentile for age, normal weight where the BMI is equal to or between 5th to 85th percentile for age, overweight when it is between 85th to 95th percentile for age, and obesity when the BMI is greater than 95th percentile for age. Of course, in the adults, very simple if you remember, it's easy to remember that grade 1 obesity is between 25 to 30 and less than 25 is normal. This is very interesting. Okay, so I'll just say obesity, grade 1 to 3, 25 to 30, 30 to 35, and more than 35. More than 40 is morbid obesity, where you usually need bariatric surgery to correct the obesity. Now, prevalence and burden. And here we should remember that South Asians, we as South Asians, our cutoffs are slightly lower than the cutoffs for the Caucasian and the European populations. So our cutoffs are 23, not 25 for overweight. And but grade 1, 2, 3, easier to remember 25 to 30, 30 to 35, like that. It's simpler, grade 1, 2, 3, obesity. Now, prevalence and burden of obesity in India. More than 135 million individuals are affected by obesity. Obesity varies from 11.8 to 31.3%, but we are mainly concerned about central obesity, and I'll be talking about this. Central obesity varies from 16.9 to 36.3%, and prevalence of childhood overweight and obesity has significantly increased from 16.3 in 2001 to 2005 to 19.3 in 2016. And there was a very interesting photograph competition where you put your picture when you were in class 10th, leaving school class 11th, like I left school in class 11th, and you put your child's picture when she was leaving 11th or 12th, whatever, and you could see a stark difference between the two pictures. So your picture and your friends when you left school and your child's picture when she left school, you will see how overweight and obesity has increased in 25 years. Now, abdominal obesity is one of the major risk factors for not just cardiovascular disease, but for type 2 diabetes. And obesity is one of the main medical and financial burdens for the governments. But what the government is doing is very inadequate. We'll be discussing in the subsequent slides. We'll talk about energy homeostasis, physiology of energy intake and expenditure. Now, what is energy intake? This is the food that we eat, the calories that we eat and drink. And what is expenditure? I'll be telling you in detail how we expend energy. Now, what we eat or the calories that we eat and what we expend, there should be a balance. And if this balance, the energy balance between calorie intake or food intake and energy expenditure is not maintained, then we tend to gain weight, or if we lose more calories, we tend to lose weight. Now, this is related to very, very simple. You'll have to concentrate on this slide. What is ghrelin basically? So when I'm hungry, I don't have food in the stomach, there is a message to the stomach releases a hormone called ghrelin. Ghrelin is released by the enteroendocrine hormone system in the stomach, and this ghrelin hormone then acts on the brain. And what does it do to the brain? It tells the brain to increase it. There is a signal that the appetite is there, appetite is increased, and the person should eat. Now, reverse happens with leptin. So where is leptin secreted? It is secreted by the white adipose tissue, and subsequently I'll tell you the difference between white and brown adipose tissue. For now, white adipose tissue releases leptin. Now, what does leptin do? It's a satiety hormone. So it promotes satiety. Ghrelin is a hunger hormone. Leptin is a satiety hormone. Now, we have to remember that there is a humoral control of eating, satiety. There is also a neurogenic control of eating and satiety. And we've heard of hypothalamic appetite center. So I'll be talking about that. Now, again, what happens when we eat? Very simple. When we eat food, the food that we eat turns into glucose. Glucose is absorbed into the bloodstream. And what happens? When the blood sugar rises, there is release of insulin from the pancreatic beta cells. What does the insulin do? It increases peripheral utilization of glucose by the muscle, the liver, and the adipose tissue. Now, glucose is utilized and the blood sugar falls. What happens when the blood sugar falls? There is a message to the alpha cells of the pancreas to release glucagon. What does the glucagon do? It increases gluconeogenesis, means new glucose production, hepatic glucose production, and also glycogenolysis or breakdown of glucose. So this keeps on happening. Eat food, insulin, beta cells, sugar is absorbed, sugar falls, glucagon from the alpha cells. So this is a very wonderful mechanism. So these are components of energy expenditure and components of food intake. Now we all know, why do we eat? One is, of course, hunger. So that we know that we are hungry and we eat. So this happens because the glucose level falls. There are certain hormones. I just told you ghrelin is released. It stimulates the appetite center. Then there's a term called hedonic. Hedonic means that certain smells, certain tastes, certain textures or variety of food promote us to eat. For example, if I am going to the market and I smell the aroma of maybe chole bhature, or for the southern population, maybe dosa, I would like to eat. I'm not hungry. I've just had a sumptuous lunch. This is known as hedonic. So very simple to remember. The smell of food, the texture of food, that feeling makes you eat. This is hedonic. Now, what is emotional or mood? We all know that. There's a birthday celebration, there's Diwali, and we all want to eat sweets. And also when we have exams, there is stress. So this is, you tend to binge when there is an exam, there is stress and anxiety. So you're motivated to eat. So these are the components of food intake. It's not just homeostatic. Homeostatic is what we want. We want a balance, that it should be homeostatic, but we also have hedonic and moods and emotional eating. Now coming to the components of energy expenditure, this I will take 5 minutes because this is a very interesting explanation. How do we spend the energy? So we eat calories, how do we spend it? So we should remember that even when we are resting, RMR, the lowest panel, resting metabolic rate, even for that during that time, or SMR, sleeping metabolic rate, we are using at least 60% of our expenditure of calories. It happens at that time. Why? Because we need calories to do our normal bodily functions, right? So that is when we are even resting. Now coming to TEF, this is again thermic effect of food. So what is TEF? These are the calories that we spend to digest food. So this is known as thermic effect of food. Now coming to NEAT. This is again very interesting, non-exercise activity thermogenesis. Now what does this mean? This means that non-exercise activity thermogenesis. It means that even if I'm not exercising, but I'm home, I'm walking around, I'm cooking, doing normal household chores, taking a bath, and walking around talking to people or watching TV, still I am expending certain energy. And this is known as non-exercise activity thermogenesis. And then of course we have physical activity leading to thermogenesis, right? So these are the various components in which I can spend my energy. Now most of us are sedentary. We don't work very hard. We don't walk a lot. Physical activity is not much. And therefore all the energy that we spend is either basal metabolic rate, where for our normal bodily functions, or the thermic effect of food. That means the energy that we use to digest the food that we eat, or the non-exercise activity thermogenesis, because we are doing some activity at home. Now, what is the advantage of doing a physical activity? When you do a physical activity, the activity related thermogenesis increases. So you spend more calories, and not just that. When the activity related thermogenesis increases, it also results in increase in the energy expenditure during resting state, right? And also when we are doing day-to-day activities, that means non-exercise activity or thermogenesis also increases. And that is why it is important. And you remember, in athletes, they have a high basal metabolic rate. What does that mean? It means because of physical activity, because in change of body composition, because they have more muscle mass than fat mass, these people have a high resting metabolic rate, and they spend more energy even during resting. So this is very important, that if we have to lose weight, it's not just the components of food intake which is important. also energy expenditure, and how you can increase energy expenditure, and how by increasing energy expenditure, how it's important by increasing physical activity, that you can also increase energy expenditure during rest. Yeah, so these are factors affecting energy balance and steady state weight. So your question to me would, how will we maintain a steady state of our weight? So that means energy going in, calories going in, should be the energy that is going out, which means how much I have spent, how many calories I have spent, or my expenditure, how much I have expended by what I explained. Now, three main factors we have to remember, very interesting: homeostatic, environmental, and behavioral. Now, coming to homeostatic, I just told you there are central and peripheral. Peripheral is usually these hormones. Now we'll divide them into two. So these are homeostatic factors driving weight gain and homeostatic factors driving weight loss. Very simple to understand. In our hypothalamus, we have two population of neurons. One are known as orexigenic and the other are anorexigenic. So which are the orexigenic driving weight gain in the hypothalamus? These are known as neuropeptide Y. So it's there, NPY, and a gout-related neuropeptide. So these are the one of the population of neurons in the hypothalamus which drive weight gain. Now, the hormone which drives weight gain, I just told you, is ghrelin, because it is the hunger hormone and it is released from the stomach, and this stimulates the appetite. Now, coming to the other population of neurons, this is in the other population of neuron in the hypothalamus is the POMC, we call it. This POMC that is present. Now, this POMC is also known as pro-opiomelanocortin. This is responsible. This set of neurons drives weight loss, right? And the hormone driving weight losses, we all know GLP-1, amylin, insulin, cholecystokinin, PYY, and leptin. And leptin I explained. I'll also explain GLP-1 here because it's important. Clinically, therapeutically, in the management of diabetes. What does GLP-1 do? We all know when we ingest food, there is release of glucagon-like peptide 1 from the L cells of the intestine. What does this glucagon-like peptide 1 do? Acts on the beta cells releasing insulin, acts on the alpha cells decreasing glucagon. It promotes satiety. How does it do it? By two methods. Acts on the central. It crosses the blood-brain barrier and promotes satiety, number one. And second, it delays gastric emptying. So food remains in the stomach for a longer time and therefore the patient feels full. So we have to remember that there are orexigenic driving weight gain factors and anorexigenic driving weight loss. And in both we have neurogenic as well as humoral, neurogenic and humoral. So this is interesting. Now coming to environmental and behavioral processes. And why we should know orexogenic and anorexogenic homeostatic mechanism is important, because suppose a patient is leptin is not there, he's leptin resistant. What does leptin do? It decreases appetite. So if he's leptin resistant, there'll be more and more appetite and he will become obese. So similarly, we could give him a leptin agonist so that there is more leptin, or we could use a drug which acts on leptin receptors, a leptin receptor agonist. So we have various ways in which you could target either the orexigenic or the anorexigenic homeostatic mechanism. Now coming to energy intake, of course, most of us eat when we are hungry, but now we tend to eat during festivals, when we just said that. So an environment drives us to eat, easy availability of fast food, so we tend to eat. Then energy expenditure. Even in the rural areas now, there is automation. People don't do as much work. Everything is easily, even cooking in the urban areas has decreased. Even in rural areas now, you don't have to do so much hard work and most things are ready-made. Therefore, energy expenditure has decreased. So these are a whole lot of things. And among the lifestyle, the hedonic reward system. I just told you that hedonic reward system, hedonic means that the smell of food attracts you. And this happens that there is a disturbance in the reward system. We'll be discussing in the next slide. So coming to the causes of obesity in children. So there are genetic causes and environmental causes. It can't be pure genetics because the genes can't change suddenly. And we've seen that lots and lots of increase. We've seen an exponential rise in obesity, which couldn't be only because of genetic factors. And we've also noticed that thin parents have a overweight or obese child. Now, what are the environmental factors And then there are many, but here we will discuss a high calorie intake, which is there. There's less physical activity, more of studies, and we emphasize in India particularly, we don't give much importance to sports. And then birth weight and postnatal status, I'll be discussing in great detail. So now, first thing is why our children are putting on weight is number one is that as the governments are not bothered, there is advertising, too much of advertisement. And this advertising sends signals so that the child tends to eat. Then sedentary lifestyle, there are not many parks and safe places for children to exercise or go. And then they have a lot of homework, as it is said. So the environment is obesogenic. So it's a very interesting word called obesogenic environment. So even if I help the patient or the child to lose weight by doing, a lot of things. Basically, what I'm doing is that the balance, I'm going to increase his energy expenditure and decrease his intake of calories. And I try to bring down his weight, but maintenance is very difficult. Reason being that the child still remains in an obesogenic environment. And what is an obesogenic environment? Where the television is, showing you beautiful pictures of people eating at McDonald's, drinking Coke. So that is the obesogenic environment. So if we have to target childhood obesity, we have to target the obesogenic environment. It's more environmental rather than genetic. Of course, there are specific genetic markers and obesity is higher. There's a high concordance rate in twins. There are genetic factors, but we cannot just ignore the environmental factors. And I've done a very interesting study in 2 schools in Delhi. These 2 schools are hardly half a kilometer apart. And you'll be surprised, doctors, that in one school, which was an MCD school, we found malnutrition, iron deficiency, vitamin D deficiency. And in the other school, which is an affluent school, we found rampant overweight and obesity, not just among the students, but among the teachers. So the issue is that we have to address, and we've done some good work in the canteens where we want healthy food to be served. So all of you who are listening, take up one school in your area. Just take up one school in your area and just repeat the same talk that I am giving over there. The importance of not putting on weight by the child. Because let me tell you, if he puts on weight, then the body weight, the system is reset at a different level. And then what happens is when it is reset at a different level, even when the patient decreases the energy intake or the calorie intake, the basal metabolic rate is so slow that energy expenditure is very slow. And that is why it's very difficult to lose weight, but it's better not to put on weight. And therefore, each one of us doctors should take up one school, talk to the principal, talk to the teachers. Believe me, talk about calories. What is calorie? What are macronutrients? What is fat, protein, and carbohydrate? How carbs, to digest carbs, you need less energy expenditure. And to digest proteins, you need more energy expenditure. So just by changing the composition of the food, you can spend more calories. This is very important. And we are a carb eating country. We have to decrease the amount of carbs in our food. So carbs have to be decreased, proteins have to be increased. And that is why we see so much sarcopenia or loss of muscle mass, because we are a poor protein eating country. Most of us are vegetarians and we do not eat the required amount of protein, which is 1 gram per kg body weight. So I don't think any vegetarian can eat 55 to 60 grams of protein in a day, because if you don't even eat an egg, so dal or milk and curd will not provide adequate amount of proteins. So that is why we have to remember fat mass and lean mass. What is lean mass? Lean mass is the weight of your muscles. It's different from muscle mass. Muscle mass is just the muscles. Lean mass is the weight of your muscle and your ligaments and your bones, while fat mass is the fat. And these days you can check, you can find out how much the fat percentage you can find out. We have these methods. Now coming back to my topic, thin fat Indian. Who's a thin fat Indian and why are we called a thin fat Indian? This is known as the Indian phenotype. And we have a very high cardiometabolic risk. This was Yagnik who first described it. And there's a very beautiful picture of Yagnik sitting with Yudkin. Both of them have the same BMI. And we have already discussed that BMI we define obesity by BMI, but BMI is not the only way to define obesity. Waist circumference is also very important because central adiposity is determined by the waist. So I may have a normal BMI and yet I may be centrally obese. The waist circumference may be more than 80 centimeter in women and the cutoff is more than 90 centimeter in men. So Yagnik and Yudkin had the same BMI, but Yagnik had more visceral adiposity as compared to Yudkin. And you can see this in a scan, a CT scan. Why does this happen? This is known as the fetal origin of a diet disease. Very, very interesting. What happens is there is maternal chronic malnutrition. So let's discuss somebody, a rural woman. She has chronic malnutrition. The fetus suffers from growth retardation. Now, once there is growth retardation and the fetus is now born, what does this fetus have? He has decreased protein-rich organs, the liver and the muscle, but he has increased adipocytes. Now, here I discuss anecdotal. Very interesting because if you listen to an anecdote, you never forget. So, I'll talk about a Dutch famine which happened because the food supplies were cut off by the Nazi forces. So, Hitler cut off food supply to Holland and therefore the Dutch did not get food and there was a famine for a few months. So all the pregnant women who were subjected to that famine had low birth weight babies, right? But once the Allied forces liberated Holland and they got enough food, so the famine was over in a few months. So in utero, the baby was subjected to malnutrition. So what did this fetus do? He adapted himself to the less food by learning to conserve fat for a day when there will be no fat. So this fetus was programmed in a way that he thought that I'm going to be subjected to starvation, let me conserve fat. This is what is known as the Indian phenotype. So our bodies are programmed as if we are going to suffer from a famine and we need to conserve fat. This particularly happens when there is intrauterine growth, there is chronic malnutrition and intrauterine growth retardation. Now this fetus is maladapted. He's actually adapting, but this will become a maladaptation later. I'll tell you why. He's adapting to the less nutrients by learning to conserve everything. Save it for a bad day. So when this fetus, the child is born and now he gets abundance of food, there is a catch-up growth. This child is more prone to develop non-alcoholic fatty liver, more prone to develop impaired glucose tolerance, more prone to develop obesity, and more prone to develop type 2 diabetes, and more prone to develop cardiovascular disease. And same thing they did. They followed up those Dutch children who were born to mothers subjected to famine. And they found that after they got enough food because the Allied forces liberated them, they had enough food. When they followed up those children who were born malnourished, they found that there was a greater incidence of metabolic syndrome. That means insulin resistance was higher because of the adaptation that prevented the fetus from dying became a maladaptation when there was plenty in the environment. So this is what is known as in utero nutritional programming. And in utero nutritional programming is such that Indian phenotype means that the Baker's hypothesis, that we are actually programmed to conserve fat, right? And therefore, when we have an unhealthy lifestyle, the environment predisposes, we have greater risk of insulin resistance, greater cardiometabolic risk, we have a higher incidence of IGT, obesity, and type 2 diabetes, and we develop all these 10 years before our Western counterparts. So we develop obesity more, we develop type 2 diabetes earlier than our Western counterparts, and we develop cardiovascular disease much earlier than our Western counterparts. And this is known as the fetal origin of adult disease. Now, this is very interesting. Do obese children grow into obese adults? The answer is yes. Now, this is very interesting. This is Dr. Nihal Thomas. The prevalence of metabolic syndrome in parents and children from a semi-urban population in Tamil Nadu. So, we must discuss what is the metabolic syndrome. It includes the waist circumference. Now, we told you the cutoffs are 80 centimeter in women and 90 in men. Cutoffs are different in Caucasians. These are the cutoffs for South Asians. Now, a high A1C. So, you can remember A, B, and C. So, the A1C, the blood pressure, and the cholesterol. And in the cholesterol, two things are important: low HDL and high triglycerides. And the cutoffs are HDL should be more than 40 in men and more than 50 in women. And the triglycerides should be less than 150 mg/%, right? And the systolic blood pressure, the cutoff was 140, and the diastolic pressure, the cutoff was 85. So when they analyzed father, mother, and child, they found that 71% of the fathers, males, had a waist circumference which was more than 90, but 84% of the women had a waist circumference which was more than 80, and 20% of the children had a waist circumference which was more than the cutoff. Now, see this, high triglycerides were found in 35% of men and 19% of women, increased systolic blood pressure, 41% of men and 17% of women, and even in children you found a high systolic blood pressure and a high diastolic blood pressure, and low HDL was found in 54% of men and 73% of women. In fact, there's a very interesting anecdote again. You mix up all the reports of the Caucasians and the South Asians, and you give them to a doctor. All the patients who have a low HDL are from the South Asian origin, because we genetically have a low HDL, and that is why, because of the low HDL, we have the the triad we have of a high triglyceride, a low HDL, and increase in small dense LDL. This is the atherogenic profile that we have in the lipids, and we have metabolic syndrome. So this is very interesting that actually the Westerners have a better HDL or better good cholesterol. So this is in utero transmission. Again, this is again very interesting. So what happens that the lady who's getting married, she is a pre-pregnant woman and she has obesity. She may have PCOD, she has obesity, she has insulin resistance, and clinically you can diagnose insulin resistance. She may have acanthosis, skin tags, she may have mild hypertension. If you do her lipid profile, it can be a high triglyceride, like we just discussed, high triglyceride, low HDL, and increase in small dense LDL. Such an obese woman becomes pregnant, and then she has excess gestational weight gain. She may even develop gestational diabetes. Now, what happens when she develops gestational diabetes? Now we know that when the mother develops GDM, high amounts of maternal glucose cross the placental barrier and reaches the fetus, but the insulin cannot cross, right? Hence, what happens? How does the fetus respond? The fetus has a normal pancreas. So if more blood sugar, the mother has high sugar, and this sugar is high, so high sugar crosses the placenta. What does the fetus do? The fetal pancreatic beta cells respond by producing more insulin. Simple to remember that the beta cells get exhausted, and therefore there's a chance to develop diabetes earlier because of beta cell exhaustion. And also what happens in the fetus, there is hyperinsulinemia. So very simple. The mother is overweight, the mother is obese, she has gestational diabetes. Because of GDM, she has high sugars. These high sugars cross the placental barrier, they reach the fetus. The fetus responds to the high sugar by, he wants the fetal sugar should be normal. So the fetal pancreas responds to the high sugar by releasing more and more insulin, and the fetus is born as in a hyperinsulinemic state. And what does more insulin do? We know that insulin is an anabolic hormone. So what does insulin do? Pancreatomegaly, hepatomegaly. That is why we are called thin fat Indians, because as compared to our body, our liver and pancreas is bigger when we are born. This is known as thin fat Indian. So what happens now? Altered fetal growth and metabolism because of GDM, altered body composition, which I just explained, that hands and feet are thin while organomegaly is present, or not organomegaly, but bigger sized organs as compared to. Now this child, if he becomes obese, then he will continue to be an adult with obesity. And if he's obese, then he has metabolic syndrome and obesity, has a greater chance of developing impaired glucose tolerance, type 2 diabetes, dyslipidemia, hypertension. If this is a late girl, then she becomes an obese girl. She gets married. Again, the same thing continues. So this is the importance that if you have a pre-pregnant obesity, excessive gestational weight gain, you develop gestational diabetes, even if you don't lose postpartum weight and continue to be obese, then you are at greater risk of developing type 2 diabetes and cardiovascular disease. So this is the in utero transmission of obesity and diabetes. This is very interesting because this means that we don't build not only primary prevention, now we have a pre-primary prevention of obesity, which means that the lady who's becoming pregnant should be normal weight, because if she's not, then she transmits this in utero transmission, the fetal origin of adult disease. So pre-primary prevention is don't allow the child to become obese. Of course, secondary is when the child or the adolescent is obese, we try to bring back his weight to normal, decrease, and then maintain the weight, which is extremely difficult, so that we can prevent type 2 diabetes, dyslipidemia, and cardiovascular disease in later life. So this is what I said. Obesity prevention starts even before a child is born. Prenatal exposure, such as excessive maternal weight gain during pregnancy, leads to obesity. Now, this is the vicious cycle of obesity in school children. This is very important. In a child who goes to school, there is a high calorie food. The parents also feed high calorie food to and then when he comes back from school, he eats in front of the television. One thing is important, that satiety signals are missed. So when you chew the food properly and you enjoy the food, then you get a signal that you are satiated. But the child misses the signal because he's eating a packet of chips in front of the television. And there are advertisements on television promoting cold drinks and fast food. And there are no games in school. Most schools in Delhi do not promote sports, and sports are not encouraged. And all the time you want to study, and there are tuitions, and there's burden of homework. Now, this increase in high calorie food initially leads to a mildly obese child. And in India, it's a stigma to call a child obese. And I remember that an obese child, girl, in fact, she was about 13, she walked into my clinic with her parents. Both of them were diabetic. And when I told the parents that she is overweight and we should do something about it, they were very upset with me for saying that this child could develop diabetes in the future, because we don't like calling our children obese. Of course, body shaming is not right, but we have to be metabolically healthy, and that is important. So don't say that the girl or the boy doesn't look nice. You have to say, sometimes the doctor ends up saying, you or the parents end up saying, you're obese, you will not get married. Let us change our mindsets after today's talk. Let us talk about the complications of obesity, the problems with obesity. We can talk to them about polycystic ovarian disease. We can talk to them about infertility. We can talk to them about developing impaired glucose tolerance, about developing type 2 diabetes, about developing cardiovascular disease earlier than their peers. All this is important. Now, what happens to the mildly obese child? It's a vicious cycle. Once the child is mildly obese, he gets tired easily, and then he stops exercising, uses the lift, his movements are inhibited, and so what we just discussed, that the balance now, he's not expending any calories. He's eating more, going on eating more, and the expansion, or he's not expending any calories, not spending, and therefore his weight increases. Now he continues to eat a sedentary lifestyle. Now what happens? Why he doesn't want to exercise? Because he's bullied in school. He's not able to run as fast. He's not able to play games like football. And what happens then? He's bullied. And when there is bullying, this child withdraws. And when he withdraws, he again stops meeting his peers, stops playing. He cannot run. He's now very conscious of his body image. And if at this point there is body shaming either by the parents or the peer or the teachers, he further restricts his movements. And this leads to a severely obese child. And when the child is severely obese, he may develop asthma. I have many patients between the age groups of 14 to 18 who are type 2 diabetics. And now he starts getting hormonal disturbances. There's a low self-esteem. And now he will grow into an obese adult. And this obese adult obviously is at a greater risk of type 2 diabetes and cardiovascular diseases. So the gist of my talk today is, how do we prevent type 2 diabetes, because it is increasing exponentially. And doctors, it is our duty. The governments have failed, the ad industry, because you all get money. So nobody wants to remove the obesogenic environment. And it is the environment which is obesogenic. So we can't do much, because if we do not remove the child from the obesogenic environment, for example, all the festivals, we have to remember exchange. So teach yourself exchange. What is exchange? Exchange means that if instead of this, I can eat this. It's very important to know exchange. So if you are eating something like, for example, if you are eating sweets, kheer, why can't you eat 1 or 2 bites of kheer and add a fresh fruit bowl with it? So we have to learn to exchange. We have to teach our children to exchange. We have to tell them to be physically more active. We have to make more parks in our own neighborhoods. And every neighborhood, we as doctors must give a talk on prevention of obesity to our adolescents. We must do school health programs to talk to the principal, talk to the teachers. Calorie charts should be displayed. We should know that a samosa has maybe a 200 calories, and to just running for almost 10 kilometers also will not be able to spend that much calories. So it's very important. Here it's important. If you take only 150 calories per day extra, at the end of 1 year, you will gain 5 kg to 6 kg weight. So imagine if you take 150 calories extra as a 5-year-old child, he takes 150 calories per day extra for 1 year, he puts on extra 5 kg. At the end of 10 years, he'll put on extra 50 kg weight. So it's important to understand the role of calories, the role of macronutrients, why we should be increasing our protein in our children, why we should be decreasing the carb a little, why we should be giving more fiber, more complex carbohydrates rather than the white poisons like sugar and salt and maida and bhatura, and how we should be increasing protein, how we should be encouraging exercise, because then not only after exercising, even the basal metabolic rate will increase, and there'll be, he'll be expending calories even for the basal processes. So all this is very important, and as doctors, it is our duty to take part in more and more such preventive programs. This is the obesity trap. I think this means, the obesity trap means that once you are already obese, then every system is reset. So you're not able to lose weight. This happens. Our patients tell us that we're not able to lose weight even if I'm decreasing my calories, because what happens? The body is now reset for a particular weight. Now, to summarize, childhood is the period where health behaviors are formed. Significant change is possible in children under 5 years. We have to teach them to be more active and eat less of junk and more of macronutrients and micronutrients. Increasing evidence from observational and intervention studies suggests that behavioral changes are possible and become increasingly difficult as the child becomes older. Therefore, type 2 diabetes is largely preventable, and we have to prevent this childhood obesity and adolescent obesity, and we have to target it in various ways, including school health programs, neighborhood programs, and so that we can actually, decrease the incidence of type 2 diabetes in the young population of our country. Thank you.
The first question is, in the offsprings of type 2 diabetes patients, does serum uric acid and ghrelin act as biochemical screening marker?
No, we're not doing routinely, because uric acid is a marker for metabolic syndrome, but we are not actually doing ghrelin in our type 2 diabetic mothers. We are not screening. We are doing other markers, but not for, I'm not doing screening for uric acid or ghrelin.
So the second question that has been asked is, are glyphosins indicated for weight loss?
No, I don't think I would give an SGLT2 inhibitor for somebody, because remember the mechanism of the SGLT2 inhibitor. We believe that in type 2 diabetics, there is upregulation of the SGLT2 receptors. So because of the upregulation of the SGLT2 receptors, the sodium and glucose that is filtered reaches the proximal convoluted tubule, and more sodium and glucose is reabsorbed because of the upregulation. Now, this happens in diabetic people, that there is upregulation of sodium glucose co-transporters, more sodium and glucose is reabsorbed, more glucose then via the receptors reaches the circulation, and higher the sugar, more is the reabsorption. Now, in a person who's non-diabetic, there will be no upregulation of SGLT2. So even if you give SGLT2 inhibitor, why do we give SGLT2 inhibitor? Because the sodium glucose co-transporters are inhibited. Sodium and glucose will not be reabsorbed in the proximal convoluted tubule. It will go through the distal tubule, loop of Henle, and some amount of sodium will be reabsorbed in the distal tubule. Otherwise, the patient will die of natriuresis, but glucose will be filtered and will go into the urine. So for every gram of glucose that is filtered, the patient loses about 4 calories. So if 70 grams of glucose are lost, the patient loses about 240 calories per day. And so he's losing 240 calories, he loses weight. This is the principle in type 2 diabetic patients. But in a non-diabetic, there is no upregulation of SGLT2, so it doesn't help. I have tried giving canagliflozin 300 milligrams, because remember, canagliflozin in that dose, 300 milligrams, also blocks the SGLT1 receptors in the gut. And the SGLT1 receptors in the gut absorb glucose. So, there'll be decreased absorption of glucose, and it may blunt the rise in blood sugar via SGLT1 receptors. And we know if there is congenital absence of SGLT1, glucose is not reabsorbed and the child will die of malnutrition. So if Canagliflozin has this SGLT1 effect and some glucagon-like peptide 1 effect. I tried, but not much weight loss happened. So I don't think it's recommended in non-diabetics for weight loss. Of course, GLP-1s are recommended. We have liraglutide and now even semaglutide can be used in obese people. And semaglutide, I must mention, will very soon be available. Now, as of now, it's available in US as injectable 1 milligram every week, and then oral semaglutide will be available. But GLP-1 drugs have really been good for the management of obesity, and we've seen patients lose a lot of weight with GLP-1 because liraglutide suppresses the central appetite center. It crosses the blood-brain barrier and suppresses the appetite center along with delaying gastric emptying, and so the patient feels full. So via these mechanisms, there's definite weight loss with liraglutide also. But we are waiting for semaglutide. So GLP-1 agonists have been used in management of obesity, but I don't think I have used SGLT2. In some patients, I tried Cana 300, but I don't think I can actually tell you. Used in about 10-12 patients, but not much weight loss because of the mechanism.
Yes, going to the next question, Dr. Madhvi Sampath has asked, what specific eye care will you recommend to children with diabetes?
It's very important. We are talking about children with type 1 and children with type 2 diabetes. So children with type 1 diabetes, of course, we should screen at the onset of diabetes and then keep screening. I screen every year and tell them to remember their birthday and screen. Although we know that microvascular complications develop only after 5 years if the patient is prepubertal. So prepubertal type 1 diabetic patients are somehow protected from microvascular complications, but post-pubertal you should check. But we check very regularly even for prepubertal patients with dilated pupils for retinopathy. Type 2 diabetic patients, of course, we check very regularly for both microvascular and macrovascular complications. So I think I recommend a dilated pupil examination every year or a fundus camera. Use a fundus camera now in the time of COVID. We are clicking pictures and sending them to the ophthalmologist with the fundus camera. So yes, it's very important. I have picked up retinopathy in as young a patient as 22. He was type 2 diabetic at the age of 15. So yes, we have to screen for retinopathy very early.
There is one last question. Dr. Ashok asks, does SGLT2 inhibitors can be first-line treatment?
For diabetes or for obesity?
For diabetes.
Yes, I would not like to use it as a first-line treatment. Other than cardiologists sometimes use it as a first-line. The European Cardiology Society said you could use it if the patient has established atherosclerotic cardiovascular disease, which means established ASCVD means either the patient had a stent or a bypass or had heart failure or a stroke or he had unstable angina. So any of these, then you can use the SGLT2 inhibitor alone. But other than that, in normal like my own practice, even if the patient has established ASCVD, I would like to use metformin and SGLT2 together. So I would use metformin along with SGLT2. Yes, if your patient is established ASCVD and cannot tolerate metformin, you can use SGLT2 inhibitors. But remember, with SGLT2 inhibitors, with great power comes great responsibility. You have to use them very responsibly in a country like India, because we are a country where it's very hot. And I just said SGLT2 causes some amount of natriuresis. Sodium is lost. So particularly in the months of May and June, July, when patients are sweating, they may complain of fatigue because of natriuresis. So you have to tell the patient to increase fluid intake. Second, uncircumcised Hindu males may develop genital infections, even balanitis and melanoposthitis. Similarly, women may develop genital infection. And if it's a male diabetologist or endocrinologist who's looking after them, they may not tend to tell the doctor and may go to a gynecologist. And then this genital infection can be missed. So I feel with SGLT2, you have to it's a powerful drug, but use it with caution. Also in people who have lower urinary tract symptoms, for example, autonomic bladders, those who have urge incontinence, diabetic patients do have these symptoms. So we should be careful. Benign prostatic hypertrophy. So SGLT2, you should know when not to use. That way DPP-4s are very, very, placebo-like drugs. You can use them easily. But Vaishnavi, we are deviating from our topic. The questions are again on management of diabetes and obesity. I would like to emphasize, doctors, that talk today is that we should target obesity in our younger population so that they don't develop type 2 diabetes and cardiovascular disease. And unfortunately, we developed type 2 diabetes 10 years before our Western counterparts. And we also developed cardiovascular disease much earlier than the Westerners. So the aim of today's talk is that each one of the doctors who's listening to me should go back and in his neighborhood, you can do a virtual program in the neighborhood, or you could address schools, you could address students of schools. Most schools, virtual programs are happening. You could address schools and talk about healthy eating. You could talk about a healthy thali. What is a thali? We should go back to traditional cooking. Dal, sabzi, roti, calories, macronutrients, micronutrients, carbs, fats, proteins, and exchange. That means one roti is equal to half a katori of boiled rice. You can't say don't eat rice to a Bengali or a South Indian, but you can tell them to exchange. So if he's eating 2 rotis, he can have 1 roti and half a katori of boiled rice, because 1 roti is. So our aim of this talk is to address childhood overweight and obesity and to talk about it, so that parents are also aware that once the child grows into an adolescent who is obese, it is very difficult to decrease weight. So it's important to prevent obesity. So each one of us should go back and do such programs with school children, with schools, with other, with banks, with other public sector undertakings. So I think this is a very good topic, and thank you for choosing it, Omnicurious. It's a good topic for all of us, so that we are discussing the preventive aspects of obesity. And if we can prevent obesity, we can prevent type 2 diabetes and cardiovascular disease.
So any last remarks to the audience?
Yeah, I think my last remarks are that we are concentrating too much on the management of diabetes and different drugs, but our focus should be to prevent obesity and to prevent diabetes. And we should actually, lesser ads on the television on food, and, we should talk about healthy, unhealthy food. Of course, you can dine out once a week, but then you can compensate. Next day, you could have fewer calories. Or you could take your child out, physical activity at home. Also, you can do physical activity and aerobic exercise. It's important. So I'll just say mild, moderate exercise. And at least we should be doing moderate intensity exercise, which means walking about 150 minutes per week. We doctors don't do it. At home, we can walk, or if we can go out wearing a mask, we should be doing. And strenuous exercise, 75 minutes a week, which could be in, 3 different sessions in a week, and 75 minutes, which is aerobic exercise. Of course, some yoga, but yoga is mainly not for weight loss, it's for strengthening. And we should be doing some resistance exercises for strengthening, because as a nation, we are sarcopenic, we have a low muscle mass, and therefore history of falls, very common above the age of 55, postmenopausal women. So my message is that we should concentrate on preventive aspect of obesity and diabetes and cardiovascular disease, and our minds are only tuned to management of these diseases. We should go back and think about prevention. Thank you.